Okay, let's begin and one by one turn on your microphone, please. I want to ask at first Maria José Alvarado. Can you turn on your microphone, dear? Maria, do you hear me? Turn on your microphone, please.
Hi.
Hi, how are you?
I'm good. Thank you.
Okay, Maria, did you read some some information from our delivered lectures?
From this lecture?
No, from the delivered lectures, not from these lectures. The first lecture and the second one also.
Yeah?
Yeah? Okay, I will ask you some questions, okay?
Okay.
Okay. Can you tell me how many phases contains history of public health? And if you can...
How many? Sorry, I cannot understand you.
How many phases contains history of public health? From the first lecture, it's a question. Now today I want to ask you from the first lecture some questions. As you know, the history of public health contains 4 phases. Do you remember?
Let me think.
No, it's a 4 phases, my dear. And the first is elimination and control of disease, the first phase. The second one is the bacteriology and immunization. The third one is treatment of disease. And
yeah.
Of course, it's managing and prevention of acute and chronic disease.
Yeah, I remember those ones.
Okay. Okay, let's another question I will ask you, maybe you will remember. Do you remember who was the first dental hygienist?
The first dental hygienist?
Yes.
Let me remember.
It's the questions from my presentation. It's very easy, and please read and learn it. Okay. The first dental hygienist was the Ira Newman. Remember, please. Okay. Okay. Thank you, Maria. Thank you. And please read information more. Okay.
Okay.
Okay. Bye bye. Now, please turn on your microphone, Marino. So.
Hello, how are you?
Hello, Marino. How are you, my dear?
Thank you, I'm fine.
Okay. Do you read some information?
Yes.
Yes? Okay, now I want to ask you some questions, okay?
Okay.
Can you tell me 2 main global entities in public health?
2 main global entities?
2 main global entities, yeah, in public health. The organizations who...
Yes, I'm just remembering.
Yes, who is looking for everything, okay? It's the 2 of them. Do you remember?
Yes, I can remember them.
Tell me, please.
They were in the chapter 2 or chapter 1?
It's chapter 1. And now today I want to ask you again the chapter 1, from chapter 1, some questions, because I think it's more important, and step by step we'll have some questions from the second chapter and so on. Okay, please, do you remember the global entities?
No, I just read the chapter
It's
2.
World Health Organization.
I read chapter 2.
And Pan American Health Organization is.
Do you mean the American Board of Dental Public Health, ABDPH?
World Health Organization and
Yes.
Pan American Health Organization.
Yes,
It's the
WHO.
two main global entities in public health. Okay. And another question. And can you describe some of the abbreviation WHO?
WHO is the World Health Organization and it's found in Geneva, Switzerland.
Yes, yes.
Um,
Mm-hmm. You're okay. Mm-hmm. You're right. Thank you, my dear. Now to I want to I want to ask now some questions to Mohammed. Turn on your microphone, please. Mohammed, turn on your computer, please. Microphone, please. Mohammed, turn on your microphone, please. Are you here? Okay, I want to ask some questions to Fuja, please. Turn on your computer. Microphone, please. Fuja, do you hear me?
Yes, I can hear you.
Mm-hmm. I want to ask you some questions. Okay?
Yeah.
If you remember, during the World War II, how many teeth were necessary in each arch to meet the military standards? If you remember,
Uh,
for recruits.
is that World War II?
Yes. During the World War II, how many teeth were necessary for recruits in each arch to meet the military standards?
Is it 6?
It's six. Yeah, it's six opposing teeth. Yes, the recruits need necessary six opposing teeth. You are right.
Thank you.
Okay. And another question. Do you remember what is the dental public health?
Yeah, I remember that.
Tell me, please.
Uh, it is a state of uh, just one second. I'm just trying to remember. Is did you mean is what is health or
Yeah,
dental?
no, dental public health. What is the dental public health? It's a non-clinical specialty of dentistry.
Oh, okay, yeah. And it's recognized by American Dental Association, right?
No, it's a non-clinical specialty of dentistry that deals with the prevention of oral disease and
And
promotion of
promotion of
oral
oral
health.
health.
Yes, it's
Yeah, yeah.
in my presentation, and you will read it. Okay, it's
Yeah,
no
sure.
problem. Thank you, Fujan. Thank you so
Thank you.
much.
Bye.
Okay, bye bye. Mohammed, are you here? Can you turn your microphone or not? Please write me. Okay, let's begin our lecture today. Today I want to explain to you some global perspectives in oral health. I have a presentation for you. Can you see the presentation? Write me, please.
No, not yet.
Not yet? 1 minute. Okay. Can you see? No, no. Pooja, can you see? No? Why?
Maria, just go to the people and press on the presentation of Dr. Khatuna. It's under the name of Dr. Khatuna. There's presentation in the people section.
People section, yeah. 1 minute, what I want. I presented it. Now you can see or not? Pooja, you can see, yeah, my presentation or not? Yes? Okay, let's begin. Yes, yes. Maria also. Okay. Let's begin. Now all of you can see my presentation or not. Please write me and let's begin, okay?
Yes, I can see your presentation.
Okay, let's begin. If you have some questions, you can write me, okay? During our lecture. Now the global perspectives in oral health care, it's very important thing. So the perspectives on oral health care are very necessarily different in various countries. And the perspectives are dependent on many factors, including demographics, oral health needs, healthcare values, beliefs, and educational and healthcare systems of delivery. And each culture has its own way of meeting the oral health needs of its people. And by its own definition, the World Health Organization is the directing and coordinating authority for health within the United Nations nation system, and it's responsible for providing leadership on global health matters, shaping the health research agenda, setting norms and standards, articulating evidence-based policy options, and providing technical support to countries and monitoring and assessing health trends. And health trends. And in 2003, World Health Organization indicated that because of the high prevalence and incidence in all regions of the world, oral disease is a major public health problem. And now influencing factors on oral health care systems. I want to explain this one. The way each country finance healthcare plays, it's no, influencing factors on oral healthcare systems. It includes the financing, population age, and oral healthcare provider and educational systems. So let's talk about to each one. Okay, the way each country, the finance healthcare plays a role in the type of oral health care provided and how it is delivered. Financing can come from general government revenues, insurance, or direct payment by individuals receiving care. Most countries have a combination of financial support, and when supported by government funds, treatment can be limited to specific types of treatment and or specific treatments for specific populations. For example, in Russia, mainstream patients pay for their own dentures. However, the dentures may be funded by the government for vulnerable populations. And so the Russia provides some dental care for all its citizens. And when a country like the United States uses a system predominantly funded by direct payment from the one receiving care, access to care is limited for those in a lower socioeconomic position. And the second influencing factor is population age, location, and oral health status have an influence on the design of an oral healthcare system. For instance, whether the country has more elderly or more children might determine the location of care. Elderly care might be more effective if provided in a nursing home, whereas many countries provide care for children in school clinics. If a large portion of the population lives in rural areas, it may be necessary to deliver care from mobile clinics. We talk about our delivered in our during our delivered lectures, mobile clinics, or use alternative providers. And if children in a particular country have a high caries rate and financial resources are limited, the focus of the system might necessarily be on restoring the teeth, whereas if the caries rate was lower, the focus might be on prevention. And health policy of each country is formulated by politicians using data on oral health needs of their particular population. And the policy reflects the health values and beliefs of the culture. And goals and objectives for actions are identified and are facilitated or restrained by available financial support. Oral health care providers and the educational systems vary in each country. For instance, the education of a dentist varies from a 2-year post-secondary training to 4-year post-university degree. And there are over 40 countries where dental hygienists practice and 50 countries where dental therapists practice. And dental assistants or dental nurses are employed in most countries, and their education varies from university education to on-the-job training. And the combination of all of these influences on oral healthcare systems makes comparisons between oral health systems and outcomes in different countries difficult. However, with the blossoming of technology, it's becoming easier to share some information and compare effectiveness of different systems. And I want to explain to you some barriers to care. We have some barriers to care, and the barriers to oral health care can take many forms. The barriers may be structural, financial, and/or personal cultural. Structural barriers are related to the number, type, concentration, location, or organizational configuration of healthcare providers. And providers face barriers and economic challenges to developing practices in low-income areas. Many providers have large loan debts, and the cost of establishing a practice in low-income areas can be tremendous. Public programs and community healthcare facilities in the United States are seeing rapidly increasing caseloads as the result of the high cost of oral health care in the private practice sector, decreasing number of providers accepting Medicaid, and a broader definition of dental indigence. And another factor, restrictive laws that prohibited the use of dental therapists and dental hygienists to provide services to special or rural populations are barriers to access to care for those populations. What about the financial barriers? Financial barriers limit access because of a patient's inability to pay for a service or providers who choose not to provide care for those with limited finances. As financing and personal cultural barriers, it inhibits patients from seeking care or following provider recommendations based on personal or cultural beliefs. These beliefs include fear of providers of different cultural backgrounds and races, fear of the system, belief in your own skills, and culturally accepted attitudes and beliefs. Now I want to, you can see in my presentation uh, everything I've done it for you. Okay. Now, what can we tell about the oral health care workforce? Although there are many commonalities in oral health workforce in countries throughout the world, there is variation from country to country as to how each particular role performs. The descriptions below are a general overview of each member of the oral healthcare workforce. The oral healthcare workforce includes the dentists, dental therapists, dental hygienists, dental assistants, dental lab technicians, and denturists. What can we tell about the dentist? Most countries have dentists who assess, diagnose, and treat oral disease. As mentioned previously, the education of dentists varies between countries. In most industrialized countries, the length of formal education for a dentist is at least 4 to 5 years in a university setting. And dentists may own their own practice, work as an associate dentist, or work in community health centers and government agencies depending on the oral health care system in the country. What about the dental therapists? Dental therapists are also referred to as expanded duty auxiliaries and previously referred to in New Zealand as dental nurses and are employed in over 50 countries. In general, therapists are employed by the government and work on children in the school system. They assess, plan, and treat children of school age, providing preventive and restorative care and instructions when necessary. They work under general supervision of a dental officer who is available for consultation and may visit a couple of times per year to do chart audits and other quality assurance tasks. The education of dental therapists traditionally has been 2 years in length and carried out in technical schools. Within the last decade, both Australia and New Zealand, which have a long and successful history with dental therapists, have combined the education of dental therapists and dental hygienists into a dually trained bachelor degree in oral health. The education is now more commonly in a university setting in these two countries. Status are being changed to allow the new oral health therapists to provide services for both children and adults in remote areas. Now about dental hygienists. Dental hygienists exist in 37 countries. The emphasis of service of a dental hygienist is to empower the patient to maintain health in the oral environment. The focus is on prevention, primarily of caries and periodontal disease. Dental hygienists assess a patient's oral health status as well as risk for disease, develop a plan of care, implement the plan, and evaluate the result of treatment. Also, the focus of practice is in most countries is similar. Government regulations and other influences tend to be different. In Holland, dental hygienists can own their own dental hygiene practice, and many do. There, much of dental hygiene care is funded by the government. In Japan, dental hygienists provide more educational services and often provide assistance to dentists. The education of dental hygienists in the United States range from 2 to 4 years. However, the European Union has decreed that beginning in 2008, dental hygiene education will be at the bachelor degree level. The International Federation of Dental Hygienists has 26 member countries, and it provides a forum for sharing information regarding the practice and education of dental hygienists in its member countries. The, what can we tell about the dental assistants? Dental assistants are used in varying degrees in most industrialized countries. Their roles range from limited duties to highly sophisticated tasks. In general, they provide support services for the patient and the dentist. An example would be cleaning up and setting up the room, sterilizing instruments, and greeting and seating the patient. The education varies from on-the-job training to some university education. And about the dental lab technicians and denturists. Dental lab technicians work in dental laboratories, fabricating appliances and restorations from structures and materials prescribed by dentists. Traditionally, they don't provide direct patient care. However, some technicians have taken additional training and are considered to be denturists. And denturists work directly with patients to create and fit dentures. And we have also the other roles in oral health care, and it's the community oral health workers are used in some countries to provide education and preventive services to people in their community. In some countries, they provide emergency care. General health aides and traditional healthcare workers provide some dental care in developing countries, and non-dental providers such as nurses, parents, school teachers, and firemen also are involved in fluoride application and oral health education. And we have some examples for oral health care systems in other countries. The countries described uh, the, about the countries described below except Cambodia are developed economies. So developed countries account for approximately 1 billion people, and emerging economies account for more than 2 billion, and countries with gross deprivation without infrastructure account for 3.3 billion people. And the latter group is concerned with more basic needs such as famine and potable water. And description of the world's population provides extreme challenges in reducing disparities relating to oral health, as we have not yet been able to provide access to care even in the developed economies. And now describe each one. What can we tell about the example for the United States of America? The United States has primarily a fee-for-service or direct care financial model. This model works well for people who can afford dental services, as there are a wide variety of services available. However, the fee-for-service model leaves many low-income people without access to dental care. Low-income minority children continue to have high rates of oral disease and poorer oral health because access in general is restricted by low dentist participation in Medicaid programs. I told you that the Medicaid programs in USA and Medicare programs don't cover uh, some insurance for patients, oral health insurance for patients. And an overall shortage of dentists to meet the needs of the population, restrictive state laws prohibiting the use of non-dentist providers, lack of oral health insurance for patients, and lack of patients' awareness and understanding of the importance of oral health. And the dental nurse concept was experimented with in the United States in the early 1970s. For expanded function dental hygiene programs were developed in conjunction with dental hygiene educational programs. This research demonstrated no significant difference in performance between the expanding functions of dental hygiene students and dental students. Similar results were reported in Australia and New Zealand, comparing restorations completed by practicing dental therapists to restorations completed by practicing dentists. In spite of the research results, to date there is no state licensing jurisdiction in the United States that allows a dental hygienist or dental therapist to prepare, place and finish restorations. There has been movement to increase access to care in many states by changing their dental practice acts and initiating alternative models of care using dental hygienists. So the Connecticut developed an alternative model allowing dental hygienists with at least 2 years experience to provide care in public health facilities without a dentist supervision. In New Mexico, an alternative model was developed as a collaborative practice. A dental hygienist may develop a collaborative agreement with one or more consulting dentists. A similar model in Arizona allows dental hygienists to form an affiliated agreement with a dentist and provide dental hygiene services for children who are below the poverty level. And dental hygiene services can be provided without a prior examination by the dentist. And several states also have expanded the services a dental hygienist may provide in Washington, Oregon, Minnesota, etc. To place the restoration in teeth prepared by the dentist. In addition, the Indian Health Service in Alaska has developed an alternative model of oral health care delivery. And also the dental health aid therapists from remote villages have the education necessary to provide many of the combined services of a dental therapist and a dental hygienist. Initially, they were educated in New Zealand and University of Otago School of Dentistry, and currently they are being educated in Alaska in partnership with the University of Washington. And what can we explain about the Canada? Canada introduced the dental therapist program in 1972. Currently, there are approximately 300 practicing therapists, most of whom work in Saskatchewan alongside. Saskatchewan is like a village in Canada. Alongside dentists, dental hygienists and assistants in the private sector providing fee-for-service care. Therapists who practice outside of Saskatchewan are employed by government agencies and don't provide services for a fee. Therapists have been self-regulated for more than 30 years. So remember that the therapists in Canada have been self-regulated for more than 30 years. Now there are 14,000 dental hygienists practicing in Canada, and similar to the United States, each province and territory has its own regulations regarding the licensure and practice of the dental hygienist. The majority of dental hygienists in Canada are self-regulated also, with means appointed members of the dental hygiene profession establish the rules for their profession. Now what about the New Zealand? New Zealand was the first country to use non-dentist providers, especially dental nurses. Now it's named dental therapists to help with the acute storage of dentists and high oral disease rates. And oral health care for children in New Zealand is funded by the government and provided by dental therapists in school clinics. Adult dentistry is provided in a private dental practice model and paid for by the patient. Also, children receive complete dental care. They may not develop an understanding of the value of oral health or the necessity of continuing dental visits after completing the SDS, it is school dental service. Because of this and the need for adult periodontal care, dental hygienists were introduced in 1989. And the first dental hygiene education program began in 1995 and the program was moved to the dental school at University of Otago in 2001. And currently dental hygienists and dental therapists are educated together and receive a Bachelor of Oral Health degree. And there are more than 250 dental hygienists practicing in New Zealand in 2008. Now, what about Australia? The Australian dental therapists can be employed through the government or in a private practice under the direction of a dentist. The dentist is solely responsible for the dental welfare of the patient. After 2 years of education, a dental therapist can prepare teeth and place amalgam or composite materials, scale teeth, administer local anesthetic, provide oral health instruction, and take radiographs. There also are over 300 dental hygienists working in Australia, most of whom work in private practice in the cities. Only a few are employed in public health or in rural areas. Access to healthcare in rural and remote areas, is greatly limited. Because of this, the Australian government has developed Aboriginal health workers. Although approximately 2% of the total Australian population is Aboriginal, and they comprise a high percentage of the rural population. Responsibilities of an Aboriginal health worker include screening and assessing, managing healthcare equipment and facilities, and interpreting information to the patient. An oral healthcare component was added to the Aboriginal health worker in 1979 that focuses on preventive dental education and non-invasive emergency procedures to affect the pain relief. What about the Cambodia? The Cambodia university-trained dentists and assistant dentists work in the public health system in Cambodia, and they work in hospital clinics in the big cities. There are also two types of private practice in the country. Please remember it. The one type is the university-trained dentists, whereas the other is a traditionally trained dentist. Traditionally trained dentists have no formal education, but are trained on the job by passing knowledge and skills from father to son. Traditional dentists are culturally acceptable and more affordable than university-trained dentists. More than 80% of the Cambodian population lives in rural areas and does not have access to oral health care. And a national survey in 1991 demonstrated high rates of dental caries and periodontal disease. Dentists were reluctant to work in these rural areas due to the lack of facilities and equipment. Working with the Ministry of Health and instituted by World Concern, the dental an American non-governmental organization, the dental therapist program was developed in 1992, and the program offers a certificate which requires 6 months of training and a diploma for 1 year of training. A prerequisite is 1 year of basic nursing education. On completion of the educational program, the dental nurses are given a set of instruments and the materials needed to provide basic preventive and curative needs, which include oral health education, local anesthetics, scaling, and extraction of teeth. They also perform the atraumatic restorative technique, which is also referred to in the United States as interim therapeutic restoration. And this provides the population with basic care at a cost the country can afford. What can I tell about Russia? The government in Russia provides some dental care for all citizens. Each citizen is assigned a specific clinic. If they visit their assigned clinic, medical care and some dental care are free. Each year, a document is prepared by the government to verify what services are provided. There are also private dental practices in the larger cities. These state-of-the-art practices center to diagnosis and an elite population. There is demand for aesthetic dental services. Meanwhile, dental decay in secondary school children has increased from 60% to 90%. In response to this increase, the government began training dental hygienists in 2001, and to date, there have been 1,000 hygienists educated. But the government oral health service isn't set up to employ hygienists, so they either work in private practice or as dental assistants in the government clinics. And in the past, stomatologists were trained to perform services much like dental therapists, and it was not successful and has been discounted. And what about the Poland? The dental care in Poland is financed through public and national service also. There are also well-appointed private clinics. Dental care is provided by dentists and dental hygienists, who are supported by dental assistants and dental technicians. Training for dental hygienists began in 1983, and the Polish Dental Hygienists Association was established in 1997. And the education of dental hygienists continues to develop as the European Union required entry-level dental hygiene to be a bachelor degree by 2008. According to some researchers, more dental hygienists are needed as 90% of children 6 years and under have dental caries. What can I tell you about the efficiency of alternative models of oral health care delivery? Overall studies report the cost for providing dental services by a non-dentist provider as lower than that provided by a dentist. Studies also indicate that more quality services could be provided at lower cost. This cost-benefit trend has been noted in the medical profession with the introduction of mid-level providers. And Nelson Thompson reported that physician assistants and nurse practitioners could substitute for 63% of physician services at 38% of the physician's costs. It was also reported that nurse practitioners could effectively provide between 75% and 80% of adult primary care services and up to 90% of pediatric care services. Therefore, these professionals can provide quality care to more people at a lower cost. If the cost to train a non-dentist provider who can provide definitive treatment takes one half of the time and resources necessary to train a dentist, it can be anticipated that the cost to deliver care will be lower. And then non-dentist providers could increase the dentist's capacity to provide quality treatment for more people at the lowest possible cost. And Rogers investigated studies related to the New Zealand dental nurse and found the annual cost per patient was 50% less than care provided by a general dentist. And success in other countries and research in the United States clearly demonstrate that non-dentist providers can be taught to provide basic restorative and emergency care. The use of non-dentist providers to perform services traditionally done by the dentist can, in fact, provide greater quantity of services with equal or higher quality at a lesser cost than has herefore been provided. The time and cost factor to train and produce this non-dentist provider amounts to a small fraction of that required to train the traditional dentist, and the application of this method can be a primary factor in meeting the needs of the public, satisfying the ideal philosophy of the profession. And what about the global prevention efforts? In addition to different models of care delivery, numerous countries have developed prevention and health promotion measures to reduce oral disease rates. These initiatives include community water fluoridation, fluoride supplements, fluoridated milk and salt, fluoride varnish, and xylitol gum. These different health promotion efforts will be described more in our other lectures, and these oral health disparities across regions and countries present a dynamic challenge in addressing oral disease. The World Health Organization has developed worldwide priority action areas for oral health, and the first action area is centered on the use of fluorides. But not only should community water fluoridation be promoted worldwide where applicable, but also other models of fluoride therapy, including toothpaste, milk fluoridation, and salt fluoridation. The second action area is associated with diet, nutrition, and oral health. Many oral diseases are affected by changing lifestyles related to diet and nutrition. This is an opportunity to partner with other programs to address common risk factors for disease. Preventing tobacco use and tobacco use cessation is the third action area. This also is an opportunity for integrating with other health promotion programs. So, the global prevention efforts include the community water fluoridation, fluoride supplements, fluoridated milk and salt, fluoride varnish, xylitol gum, and also the World Health Organization has developed the worldwide priority action areas. And this action area, the first action area is centered on the use of fluorides. The second action area is associated with diet, nutrition, and oral health. And the third one is the preventive tobacco use and tobacco use cessation in a third action area. Please remember this. It's important. And World Health Organization has targeted both ends of the age spectrum. It has launched programs in schools and with youth populations to control oral health risks for young people. In addition, this staggering growth in the older population worldwide presents a challenge, both in numbers of people and the impaired mobility to obtain access to care. Finally, oral health systems have been targeted for improvement. This includes examining various models of care delivery, developing new categories of personnel to fit a country's needs, payment systems, information and surveillance systems, and building and strengthening research programs. And oral disease is one of the most prevalent diseases in the world, causing considerable morbidity, particularly for disadvantaged populations. To address these problems, many countries have utilized a variety of providers to help ease the burden of care needed with less cost. Many of these successful models of care could be adopted on a wider scope to bring more quality care to more people and complete more pieces of the dental public health puzzle. And oral disease has many risks common to other diseases affected by lifestyles, and working collaboratively with other healthcare providers and organizations can provide a more holistic approach to health. And the World Health Organization has set priorities for coordinating efforts for addressing oral disease and disparities worldwide. And nations can learn from each other and work together toward these priorities. This is our lecture's information, and now I want to ask you some questions, my dear student. How do you, 1 minute please.